So let's move on and talk about potential causes of stroke. So after our patients get admitted to the hospital, the next thing we have to figure out is why that stroke happened so we can prevent it from happening again. I'm a simple guy. So the way that I like to think about it is someone once called it the ABCs of strokes. Now, most people who do more stroke care than I have in my lifetime have more specific criteria that you'll hear about in our clerkships. But for now, we'll keep it fairly simple. So I think about A for arteries, so large and small vessel. We look at vessel imaging, so angiogram, CT angiograms, MRIs, carotid ultrasounds, and even something called transcranial Doppler, which is another form of ultrasound. Those are ways to look at the vessels and see if they are open or they're stenosed or closed off. The next thing is B for blood. So I wouldn't put too much attention on this for this particular course and this lecture, but for our younger patients who suddenly have a stroke, we wonder why did that happen? And oftentimes we look for maybe they have a hypercoagulability that's caused that issue. And the next thing, C, is for cardiac. So basically, we're thinking about two main things. Maybe there's a structural issue, but the most common thing and the thing that we'll talk about a little bit today, and I want you to remember, is something called atrial fibrillation. You have not had your cardiovascular module yet, but when you do, there's something called atrial fibrillation that can cause an irregular type of heartbeat that leads to small emboli that form and then find their way going up to the brain. We look for that via basically something called an EKG that you will run into later on. We'll also wind up doing an echocardiogram, which is an ultrasound of the heart, to look and see if there's a structural abnormality of the heart as well. And then the last thing we should mention is this Holter monitor, which is basically a longer version of an EKG. It will be on there on the patient physically while they are lying down in the hospital. So I'll talk about carotid stenosis. So there's three mechanisms for problems that can be caused by a symptomatic carotid stenosis. So one is hypoperfusion, so a lack of blood supply, because essentially you have all this blood trying to make its way through this tiny little thing. So that's a big cutoff, right? So you can get hypoperfusion from that. You can get thrombosis or emboli. So basically things start working their way up from either the clot or even from the heart, and then wind up going to the brain and causing strokes. The way to deal with that is basically to open this up. And there's a couple of main ways to do it. One is surgically, something called the carotid endarterectomy, where we actually surgically open this up. And in some cases, if the patient can't physically handle a full-on surgery from a carotid endarterectomy, we might do a stent instead. So here's a picture of what a carotid endarterectomy may look like. Basically, we open up that blood vessel, we take out the emboli itself, and then we stitch it back up and put a little graft there to maintain the integrity of that spot where we actually did that procedure. So that is very helpful for a lot of the patients if that artery has caused their stroke. So the next thing we're going to talk about is thinking about the ways that certain types of strokes happen. So we'll be talking about ischemic infarcts, which can be caused by atherosclerosis or thrombosis, or hemorrhagic infarcts, which can be caused by other different types of vascular issues. So vasospasm, extrinsic compression, reperfusion, and then emboli can be associated with either one. Isn't that right, Dr. Goktin?
Yes, sir.
All right.
And I would like to interject, if I may,
yes.
to emphasize the reperfusion injury. And that really ties very good to the time limitation that we have to apply any thrombectomies or TPA application, because once the tissue is dead, it is not only brain tissue, the blood vessels are also dead in that region. And if you remove the blockage after a certain point in time, the blood will rush in, and those dead blood vessels will not withstand that pressure anymore. And now your infarct will turn into a hemorrhagic infarct. And that is a serious complication. And it can happen on its own too. For instance, a thromboembolus may just dissolve on its own, may move further and open up some space for blood to rush in, or vasospasm may be relieved and blood comes in now. So this is a serious complication, hemorrhage on a previously formed infarct, also known as reperfusion injury. And I don't know if there is anything to be done when that happens.
You know, that concern about reperfusion that you brought up right after the stroke is the reason that we have to be very careful about the timing of giving IVTPA. If we wait too long, then that tissue is at risk for having that reperfusion injury. So something to keep in mind, but you'll see a lot more of these decisions being made when you hit the clerkships in a couple of years. Here we have atherosclerosis. What are we looking at here, Dr. Cockton?
Very bad vessel. Whole bunch of arteries. We're looking at the circle of Willis dissected out. And towards the bottom is the basilar artery. And at the very bottom are the vertebral arteries. And as you can see, I'm sure you saw by now some normal blood vessels, or so-called normal, probably not this bad. Now, these blood vessels are, first of all, yellow. And they have these convolutions, and they're very thickened and distorted. And in the cross sections of the internal carotid arteries at the top, we can see how thickened and yellow the wall is. These are also calcified, exactly. These are also calcified, very firm if you were able to palpate them. And so this is your typical atherosclerosis, meaning that we have atheroma plaques all over the place. Now, I understand that your cardiovascular module is coming up at some point next year. But let me briefly summarize what this atherosclerosis, arteriosclerosis is, so that we will use these terms and you have an understanding. When we talk about the problems with the blood vessels in terms of their stiffening, we refer to it as arteriosclerosis. Arteriosclerosis. It comes in three varieties. The most famous one is atherosclerosis, which involves the large blood vessels like the aortic arch, common carotid artery, internal, external carotid arteries, femoral arteries, etc., and medium-sized, like the ACA, MCA, coronary arteries. These are characterized by atheromas, lipid accumulations and the reaction to them, which eventually can erode, result in thrombosis, thromboembolism, result in hemorrhages into the blood vessel wall, calcifications, and ossifications. And eventually, of course, narrowing of the lumen. That's the part that is most concerning. The second variety that is clinically significant is arteriolosclerosis, which means small vessel disease. And small vessel disease is actually a technical term that we use as a diagnostic line. That refers to the involvement of arterioles by concentric collagenous thickening in response to, most commonly, to hypertensive and diabetic injury. Those are usually parenchymal injuries, parenchymal blood vessels in the brain, mostly in the white matter, and they have a more diffuse effect on the brain parenchyma. And the third type, which is not relevant to our talk, but so that we have it mentioned, is medial calcification, also known as Mönckeberg sclerosis. Don't worry about the name. It is kind of an innocent calcification in the media of the medium-sized blood vessels. We usually see it as an incidental finding in some resections, like from thyroidectomies or hysterectomies, and they do not have a known clinical significance. So now we are looking at the atherosclerosis, and note that the basilar artery is curved like a S or C shape. That is called dolichoectasia. And that is also commonly seen by radiologic examination. Of course, I only see them when there is an autopsy, but it can be so extreme that it can just bend over to the side and start compressing some cranial nerve roots, causing some cranial nerve palsies in some extreme cases. If you look at this blood vessel, this artery on cross section using a microscope, you see that the lumen is extremely narrowed, probably down to about 40% of its original size. And down at the bottom left of the picture is a lot of calcification and probably even ossification. And all the rest of those pink areas are fibrosis, fibroblasts, histiocytes, lipid accumulation. And eventually, of course, if you let it go, it will occlude the entire lumen or result in some surface erosion and thrombosis. That's how heart attacks and strokes can happen. Yeah, this is the thrombosed version of a similar lesion. So now we don't see any lumen. The holes that are kind of a cleft appearance, those are cholesterol crystals that melted away while we were processing the tissue, and therefore we see them as empty spaces. But note that there is red blood and a lot of cholesterol crystal clefts, and this is a fresh thrombus or maybe an embolus coming from an atheroma plaque that is occluding the entire artery lumen. So whether it's in the coronary arteries or one of the cerebral arteries, as you can see, it's a very dangerous thing to have.